Thank you very much for your attention. Thank you to Martin and the organizers for the opportunity to give this presentation. And I'm delighted to give the first readout of the results of the NeuroSAFE PROOF trial. This is a multi-center, randomized, controlled, patient-blinded study evaluating the use of the NeuroSAFE procedure during robot-assisted radical prostatectomy. And I present this work on behalf of my co-investigators. My only conflict of interest is that I've received funding to attend the EAU. When we perform robotic radical prostatectomy, we perform a balancing act, balancing the opportunity to remove the cancer and cure it with the potential side effects that come from removing important functional tissue that's closely approximated to the prostate. And we perform nerve sparing and try and spare the cavernosal nerves to try and minimize the side effect profile. But commonly, radical prostatectomy results in urinary incontinence, which is usually a temporary problem, and erectile dysfunction, which is usually a permanent problem, more acutely felt by those patients who are young and sexually active prior to their surgery. The problem we have is that it's very difficult to know the exact extent of prostate cancer and how it relates to the nerves that are closely approximated to the prostate capsule. We tend to err on the side of oncological control, and many patients who have organ-confined disease on the definitive pathology have non-nerve sparing surgery. We don't spare nerves when we could have. The NeuroSAFE procedure is an intraoperative frozen section technique. The surgeon gets feedback in real time during the operation. Having performed a nerve spare, they get to find out if that's resulted in a significant positive surgical margin, which may represent an issue with oncological control, and it gives them an opportunity to regain that oncological control by performing a secondary resection. To date, the evidence behind the use of NeuroSAFE is limited to studies that are felt to be at risk of bias. So we set out to evaluate NeuroSAFE in the best way we know with a randomized controlled trial. We recruited men who had selected robotic radical prostatectomy as the primary treatment for their localized prostate cancer. All men had a pre-biopsy MRI. All men reported good erectile function without the use of medication and were continent of urine. Once recruited, all men were considered at a preoperative surgical planning meeting, and a personalized nerve-sparing plan was developed between a urologist and a radiologist, reviewing all of the available pre-operative clinical information, MRI scan, biopsy results, and a recommendation was made for the degree of nerve sparing perceived to be safe on each side of the patient's prostate. Thereafter, the patients were randomized. Half of the patients had NeuroSAFE performed during radical prostatectomy with bilateral nerve sparing as default and secondary resection of the bundle as appropriate. The other half had radical prostatectomy performed according to their personalized nerve sparing plan. Our primary outcome was erectile function at 12 months, measured with the IIEF-5 patient-recorded outcome measure. The secondary outcomes were urinary continence, reported using the ICIQ short form PROM at 3 and 6 months, as well as erectile function reported using the IIEF-6 PROM at 12 months. We recruited over 4 years. Despite 2 national lockdowns for the COVID pandemic, we were able to get across the line on time and target. And that's testament to the determination and adaptability of the research and clinical teams at the 5 UK hospitals where these patients were recruited. We analyzed our data on a modified intention to treat basis. This was to minimize bias. All patients who underwent surgery were analyzed according to the group they were allocated to. The randomization seemed to result in a good distribution, an equal distribution of clinical and patient parameters. Bearing in mind the recent recommendations on prostate cancer research from the Lancet Commission, we were pleased to see that 30% of our patients were recruited from Afro-Caribbean heritage and 5% from Asian heritage, and that makes our data applicable to the patient group that we serve. We're also pleased to see that only 3% of the radical prostatectomies we performed were performed for low-risk prostate cancer, Cambridge Prognostic Group 1, which was reassuring. In the operating theatre, we found that surgery took longer with NeuroSafe, on average 43 minutes longer in the NeuroSafe arm than in the standard arm. But that investment of time translated to an increase in the amount of nerve sparing that we were able to perform, with 82.1% of patients getting a bilateral nerve spare in the NeuroSafe arm versus 56.4% in the standard arm. We observed a very high level of data completeness. Over 90% of the patients who underwent surgery provided data for the primary outcome. And here are our results. For our primary outcome, erectile function measured using IIEF-5 at 12 months, we saw an adjusted mean difference of 3.18 in favor of NeuroSafe. For the secondary outcome of urinary continence measured using the ICIQ at 3 months, we saw a 1.41 point difference in favor of NeuroSafe. That difference was not observed at 6 months. Using the IIEF-6 PROM at 12 months, we observed a 3.92 point difference between the two groups, again in favor of NeuroSafe. So what does that mean for patients? Well, it's quite difficult for a man to understand what going up 4 points on a questionnaire means, so we present the data here in a different way. This histogram shows the breakdown by categories, the standard categories used to describe potency for the IIEF-5 PROM for the two groups over the time course of recovery over 3, 6, and 9 months, and 12 months. And the highlight is here. So at 12 months after surgery, almost twice as many men in the NeuroSafe arm reported no or mild erectile dysfunction. In terms of our oncological outcomes, we saw very little difference in PSA persistence and biochemical recurrence. We did see an increase in the application of adjuvant treatment in the NeuroSafe arm. 4 times as many men in the NeuroSafe arm received adjuvant treatment. But it's worth bearing in mind that this is treatment that is administered on the perception of adversity based on a pathological report. This is not driven by PSA. It's also no longer recommended practice. The EAU guidance against adjuvant treatment was brought out based on high-level evidence early on in the study, and we saw 80% of these adjuvant treatments applied during the first year of follow-up in the study and decreased rates during the course of the study, which was reassuring as the guidance came into force. We performed a predefined subgroup analysis, so hypothesizing that the men who stood to benefit most from having the NeuroSafe procedure were those men who would not ordinarily be offered bilateral nerve sparing. We looked at the group who would not be offered bilateral nerve sparing. And indeed, we saw an increased benefit. So these patients had a mean difference of 4.4 in favor of NeuroSafe compared to 3.18 in the entire cohort. We didn't observe a similar difference with the continence scores in this subgroup analysis. In conclusions, performing NeuroSafe during robotic radical prostatectomy results in improved erectile function at 1 year and improved urinary continence at 3 months, but that improvement in urinary continence is not sustained. The benefit of using NeuroSafe is greater in patients who would not otherwise be offered bilateral nerve sparing. We observed similar oncological outcomes at 12 months, but we acknowledge that 12 months is a very early endpoint for oncological outcomes in prostate cancer. We will report on subsequent time points as our data matures. To our knowledge, this is the first randomized controlled trial which demonstrates a benefit to an intervention in terms of erectile function recovery performed at radical prostatectomy. I would now invite you to take out your phones. In a moment, I'm going to show you a QR code which links to the Lancet oncology paper for which the embargo is now lifted, and you should feel free to download it. It's open access, so it's available free of charge. The final thing for me to do is to acknowledge my co-workers. So across the 5 UK NHS centres, the research and clinical teams who contributed, at UCL, the NCTA Clinical Trials Unit, our statisticians, health economists, data managers, importantly, our independent data monitoring committee and our trial steering committee members. I'd also like to thank our funders and last but certainly not least, the patients who participated and provided this data. Thank you very much for your attention. Please feel free to download and digest at your leisure.
Thank you, Greg.